having me, and I feel particularly honoured to have John Howard in the audience listening to me. So thank you very much, and to be at this particular function. Now, basically, my background is I'm an infectious diseases physician and clinical microbiologist at the Canberra Hospital. I'm also at ANU because you get basically a co-joint position, and that's because I'm also into research and other things. So I'm particularly involved in infection control and prevention, and I've been so for 30 or 40 years. And my view of COVID, it's essentially an infection control and prevention problem. So that's why I've felt so strongly about it. And I think there's a lot we've done right. There's a lot we could have done better. And predicting the future, I still think is a little bit difficult, but I'll give it some go. So just for way of background, I mean, I've just put that there if anybody wants. There's some scientific peer-reviewed papers I've been involved in. One was about a year ago, or a bit more a year ago, with the College of Physicians. And essentially, when I look and reflect back what I was sort of saying we needed to do back then, the main thing I think I got wrong was I was expecting vaccines to be much better at stopping transmission. They are very good at stopping you dying or decreasing your risk and stopping you getting into hospital. But I was, and I'm on record of saying, oh, well, you know, they'll decrease transmission probably by 80%. Well, I think that's patently wrong, given that half the Australian population has been infected in the last 6 months probably, and we had 95% of adults. And the other thing that I have a real thing about that I think we haven't done properly is eye protection. Because if you have anything drop into your eye, it goes straight down to your nose because there's a nasolacrimal duct, and I think we've neglected that as well. I'm on the record also in the media for different opinions, and this is one that I had an opinion piece quite a long time ago, the debate about whether we should take the New Zealand approach, and you might remember, and still, the Swedish approach. The Swedish approach was not to have lockdowns, and Sweden was anathema, and to a lot of people it still is. New Zealand, I still think Australia has actually took the best approach, and I'll try and justify that in a minute. But I still think that's correct. I mean, the real issue, I think, with COVID is it overall probably has a 1 or 2% mortality on a population base, but obviously much higher if you're older. But what it means is you've got to buy time and stop the transmission of the virus until you can protect your population as much as is reasonable, and that means vaccination. So a lot of the restrictions were quite reasonable. How tough they needed to be, we probably need to learn, and I'll try and touch on that as well. I put this up, this is from the Australian last weekend, because there's a view that Australia is not doing very well. Well, I think that's false. Australia has done very well. And if you basically look at this thing, this is deaths per 1,000 people in the population, and this is the amount of cases you've got. You want to be down this end of the graph, because it means you have had, in your population, you've stopped people from dying, basically. Because if you look at Australia as, say, if 10 million people are infected, with a 1% mortality, that's 100,000 deaths. Now, we're up to, I think, 7,000 or 8,000, so quite a bit. But if we had had this happen a year or two ago, we would have had huge numbers of that. That's why the UK and the US have done so badly, because they had to go through the population when they basically didn't have immunity. So we're in a quite different situation. And again, I look at this, and basically Australia and New Zealand are about the same ballpark. Oh, sorry. Australia and New Zealand are about in the same ballpark, and essentially also, if you look at Sweden, which is one of the pariahs, it's in the same ballpark as Germany, as far as deaths is concerned. So I think we need to get over the politics and you were right and you were wrong. See, how have people ended up? Because I think at the end of the day, the main criteria, and I don't think we'll be able to measure it for another 12 months, I might say, is how much of your population has died due to COVID, and then also how many excess deaths have you had? Because if you lock everybody down from COVID and people are dying from diabetes and heart disease and suicide, that's a problem too. So it's the total amount of deaths and suffering you've had in your society. And then we need to learn from that and say, what did we do wrong? What could we have done better? Learning from other countries and what they've done. Now, this is not perfect science because there's not good control groups, but we need to do better than I think we've done now, where people seem to have one extreme or the other, which is a problem. Now, if I get into something non-controversial, like where did this virus come from? Well, I think it came from bats, and I think everybody agree with that. Did it come from the Wuhan lab and a leak? Well, I think that's still possible, and I do think, we need more material. But could it have come directly from wild animals to some other animal and then to people like, SARS-1 did? Yes, it could as well. The short answer is we don't know, but dismissing completely laboratory, I think, is a big mistake. The reality of that lab, that's where the outbreak was occurring. And interestingly, we can blame the Chinese, but the NIH US funded $3 or $4 million to do research there they weren't allowed to do in the US, which was gain of function, making something more virulent. Now, we do that all the time around the world. I've always been, had problems with that because I think, how does that actually benefit us if we make a flu virus that actually is better at killing people in a laboratory? What happens if it gets out? And there's been lots of laboratory leaks over the decades, everything from smallpox to probably one of the circulating flu viruses we've got now. And I haven't seen anybody come up with a better drug, a better vaccine or anything for all that. So I think there needs to be a lot more control of what's done in labs. And just an example, when you try and get a virus and grow it, well, you need to grow it in cells because it needs live cells. So in Wuhan, as far as I can see, they used monkey cells and some human cells to grow their bat viruses. Well, if you want to humanise a virus, I can't think of a better way of doing it. I mean, we worry about a virus coming from a bat to a person, and normally it doesn't because our cells are wrong. We've got the wrong receptors, so it drops off. Occasionally it happens. But if you then passage it in a laboratory for a couple of years, well, guess what? It's humanised because it's growing in human or monkey cells. So it strikes me there's a lot of basic things we do in laboratories that we've got to relook at. And if mostly it causes a mild disease, well, somebody gets it, gets a mild cough, goes home and spreads it. Because COVID is not lethal to everybody. In fact, the majority of people, particularly if they're young, still have just mild disease and they had a pre-vaccine. I put this up because this is the first slide of what happened in 2020, and you can see two peaks there. And the first one was about March, April 2020, and then that second peak was when Melbourne had their outbreak from the hotel leaks. And you can see there were quite a number of cases, and particularly with that second one, there was actually quite a few deaths. Now, interestingly, that first one, you might notice it like an epidemic curve. It goes up and comes down. Interestingly, it went up and went down in every state. Now, this is about the time that people were starting to talk about elimination and zero COVID. And my point is, if you look at the Australian states, all of whom had lockdowns, they weren't the same all over every state. Victoria had the hardest one, no visitors to your home at all. New South Wales, I think, let you have one visitor. Here you had 2 or 3. And there were different restrictions on whether you could go outside or not. But the end result for all of them, much to my surprise, I didn't think we'd be able to get zero COVID. We went down to 0 again with the original strain. So my view is that we need to learn from what we did and say, well, yeah, look, we need to put restrictions. We needed to do things, and I think closing pubs and clubs was a good idea. But stopping people going for playgrounds, stopping people going outside, locking them up for only allowed to go outside 1 hour a day. I think there's a lot of things. Driving your car with a mask on when you're the only person in the car, wearing a mask outside. A lot of those had marginal, no extra benefit, but a lot of inconvenience, including not letting people go outside. Now, I put this up because this is where we're at now. And you might notice if you try and look at the 2000, and you can't even see those blips. This is the difference now with the number of cases. Those original 2 things, they're insignificant on the line. So there's a lot more cases. We do have a lot more deaths, but your risk as a person is much, much less. It's now actually about the same as influenza, providing you're vaccinated. And we've done very well with vaccination because Australia's got one of the highest vaccination rates in the world, and ACT sort of, even a bit better than that. But, it's very different now. And it's interesting is that to a large degree, COVID's fallen a bit out of the news, even though the risk is still there. For an individual, the risk is much less, but for a population, it's still an issue. And I'm actually surprised I must admit, that we've still got this ongoing number. Even in a place like the ACT, we're having about 1,000 cases a day. And for every one case we diagnose now, there's probably 2 or 3 we're not. that it's been going on for so long. Now, this is because of all the new strains that get introduced all the time. And while the vaccines are very good at stopping you dying, getting seriously ill, they're not very good at letting it not replicate in your nose and then spreading it to others. And that's an issue about what vaccines we might need in the future, or do we need them? But anyway. I put this up because this is the perspective of who gets COVID. The biggest group that get COVID are 20 to 40-year-olds, not the elderly. Now, that's of some significance, and people argue it, is if this was influenza, the 0 to 10-year-olds would be off the scale. They get 4 or 5 times more than adults. In this particular case, adults get it more than children, probably because the receptor we have to have in our nose and our respiratory tract is called an ACE2 receptor, and children have less of them. Now, I say, thank goodness. But I might say there's still a lot of people who believe children are the font of all infections, and that's the reason they're all spreading around. And that's why we have to close schools and preschools and everything else. I think the data is quite different to influenza, even though pandemic plans are based on influenza. And that still is an ongoing issue with huge social and economic costs for a lot of people with school closures. And again, if you put in perspective of what matters a lot, which is deaths, you can see the vast majority of people who die in Australia are those over the age of 70 and particularly over the age of 80. So the biggest risk for death is up this end, but that's not where the biggest infections occur. Now, these people can spread it to those, so that is an issue about what you do about, restrictions on people. But, this is an issue with restrictions as well. Often the people who benefit the most from restrictions are people who don't have income problems and are often better off because they can work from home. And the other thing is, every study you look at around the world, if you're socially disadvantaged, you have a 4 or 5 times higher death rate than somebody who's in a well-off position. So, and often when you put restrictions in place, disproportionately it hits the less, socially disadvantaged. So that's all issues as well. This again is, from the original strain, the different mortality rate, and essentially if you're older, it's a really bad idea to get COVID. If you're over the age of 80 and you get COVID and you're unimmunised, you've probably got a 1 in 10 chance of dying. But if you're a 30-year-old, it's 1 in 10,000 chance. And that's of some significance with vaccines as well, because often the vaccines are much less benefit if you're younger, relatively speaking, but you have more side effects if you look at clotting or even cardiac. So, we tend to look at this as too black and white, but there's a balancing act here in how many doses you give people. In England, for instance, for teenagers, they recommended 1 dose of the Pfizer vaccine because of the cardiac side effects. You did not get as much protection. You got about 70% protection instead of 90%. But the trouble is, if you got the second dose, it tripled your risk of the cardiac side effect. So there is a balancing act here, and everybody is not the same. And it's the same for young children, 5 to 10-year-olds and 0 to 5-year-olds. Yes, they can die. Yes, they can come into hospital, but their risk is very low. And you've got to then start weighing that with the vaccine and how good it is. And I might say the data I've seen, yes, it protects you, but it's not that flash. It's much better in adults. So you've got a group you're going to vaccinate where the benefits are much less, and the side effects may actually be equal or even more. So this is an issue that has to be looked at better, rather than I'm very pro-vaccine, let me tell you, but it's not that it's the same benefit versus risk for everybody. What did we do right in Australia? Well, one of the things we did, and we did very early, was border closures, international border closures. I'll leave off state borders till some later discussion, but international borders made a lot of difference. It stopped a lot of importation into Australia. The other thing I think was interesting, the bushfires we had at the beginning of the year, I think that helped too, because everybody thought Australia was on fire and we had a lot less people coming here from China and everywhere else can bring the virus in, but that aside. For whatever reason, and border closures was the main one, that was a pretty politically courageous decision. Australia got criticised for that, the Europeans in particular, about we're being racist and a whole lot of things, but it was a very good decision. And particularly because I don't think we got all the information out of China very early. I remember in the media in 2020 in January saying, we don't have a problem in Australia. This virus is only transmitted from animals to people. We won't have a problem. I was on the record. And that was because that was what was coming out of China. I think our chief health officer said the same thing, so I didn't feel quite that bad. But China obviously knew this was person to person, at least in December, and kept that information not in the public arena. It's only when they started having cases in Japan and Korea, and it was obvious that they started being more for things. So I think it was fairly courageous to make that decision. I think it was the right decision, as was hotel quarantine. That was criticised as well, but that decreased the risk of transmission by a factor of about 100 in Australia. Was it perfect? No, it wasn't, and it was a real disaster in Victoria, but they didn't get very good infection control training in Victoria. You know, there's a whole lot of issues, I think, how that was done. New South Wales, I was on a federal health department review of these hotel quarantines. I was very impressed with New South Wales, how they did it. And the reality is, in the first year they were doing it, they had no staff or other members who got a leak. And even when the Delta one did come as a leak from New South Wales, you know, late last year, it was actually not to do with hotel quarantine. It was with a pilots or staff from a cargo plane and an unvaccinated driver. So hotel quarantine, for all the criticism, was very effective at markedly decreasing the risk. Did it make the risk zero? No, it didn't. But you can't make the risk zero with anything, so you've got to be realistic. So I think that was success. But the other issue is vaccines. Now, again, I think a lot of the criticism was levelled was, you know, unjustified. We managed to get vaccines very early in Australia. Now, you can argue what should they have bet on. The federal government bet on the University of Queensland vaccine that fell over because it had a HIV molecule in it, and people ended up with HIV antibodies that used it. But then they actually said the AstraZeneca and CSL produced that in Melbourne. And yeah, look, the Pfizer vaccine and the messenger RNA ones are very good, but we didn't have production facilities here. And not only that, it was an untested methodology. So a lot of my colleagues were really getting stuck into the government for not having messenger RNA, you know, Pfizer vaccine here. The reality is, the US did not allow any export of that until about May or June. They kept it for themselves and then Canada. The Pfizer vaccine we got from Europe, much to my surprise. I mean, I was surprised we couldn't lean on the Americans to get it, actually, but anyway, we were obviously not very successful. I got a Pfizer in March because I'm a medical practitioner and working at a hospital, and there was more available then, but AstraZeneca started becoming available, but it was undermined by firstly all people saying wait for Pfizer because they had the view that we could eliminate the virus because we'll have a better vaccine at stopping transmission, which Pfizer at the time probably was. But the end result from that is there were a whole lot of people over the age of 70 who didn't get vaccinated even though the vaccine was there. And that was a reason that many hundreds of people died in Melbourne and at the end of the year because they were waiting for Pfizer when they could have been protected. Yes, there were clots, but the reality is you had a 1 in a million chance of dying of a clot, less likely if you're older, versus if you know, 500,000 people got infected at the age of 70 or 80, you would have had tens of thousands of deaths. So I think there was a whole lot of information that went out about side effects that undermined and slowed down the people who really needed it, which were people over the age of 70 in particular, getting vaccines at a timely time in Australia when the vaccine was actually available. And I blame the media and a lot of my medical colleagues for politicising it and really undermining the AstraZeneca vaccine, which is a very effective vaccine at stopping you dying, particularly if you're older. The benefits so much outweigh the risks. Yeah, and on that, sorry, I'll go down to the last one. The reality is, if you want to see what the problem is with having zero COVID and that mentality, look at Hong Kong. They had no COVID until relatively recently, 4 or 5 months ago. The end result was a large proportion of their elderly over the 80-year-olds were not vaccinated, about 30%. So they've got a much higher death rate than Australia because the people that needed to get vaccinated didn't get vaccinated. So, you know, a lot of this closing your borders and we can eliminate and have zero COVID induces a sense of, I'm fine, I don't have to rush and do this. So that when it eventually comes and it will go everywhere, eventually you have more deaths than you should have because you didn't protect the people most vulnerable and in fact more people as well. Now what about lockdowns? Well, I think the reality is if you have a virus with a high mortality, and I might say, you might remember the pandemic plans were put in for bird flu, which had a 25% mortality. So, you know, what the plans were for, in fact, much worse. Probably 1 or 2% mortality is with the original strain of COVID. It's difficult to know how many infections you missed, but Australian data was probably pretty good, and it was between 1 and 2%. And originally it was, look, we'll suppress this, flatten the curve, you remember? And I thought that was a really good idea, but we did better than that. We made the curve come down. We actually achieved zero COVID in every state in Australia. But around that same time, there became a belief that, look, the harder we go, the better we'll do and the quicker we'll get it down. Now, I actually think the data and evidence for that is poor. Look at New Zealand, which was the first Western country to adopt the Chinese approach, which was zero COVID, quickly followed by Victoria. But I'm hard-pressed to see that Victoria did better than New South Wales. New South Wales had big outbreaks from the Victorian, you know, something coming up at, you know, around the Campbelltown area. But also again in December, January, when they had the outbreak in the northern suburbs, they managed to get back to zero COVID without really stringent lockdowns. And my other view on this is it all became very political, but you remember, I think, you know, what was it, October last year when, or September, when there was Delta and it, you know, spreading in Sydney. ACT, we had 1 case and we locked down because we were going to show New South Wales how to do it properly. Well, that wasn't very successful. Victoria did it with about 10 cases. Oh, that wasn't very successful either. And New Zealand was going to do the same. So none of it has worked. Now, it did work in Taiwan, I might say. They managed to get rid of Delta by reasonable restrictions. I don't think quite, you know, a stringent lockdown. So it's not as if people didn't do it. But, you know, and now that Omicron is here, you've got Buckley's, in my view. You're not going to be able to do it. So, you know, my view is you need restrictions. But what level of restrictions you need, I think we need to be careful about. You know, closing playgrounds, stopping people going outside. I think the extra benefit of that was pretty marginal. That's different to closing pubs, nightclubs, and even gym. There were places where this spread. But most spread occurs in the household and in the workplace. And, you know, there's issue about having more outside air. I'll try and get onto with that as well. So China is still trying to get rid of this now. Hong Kong, they're still getting increasing cases. They've got the Chinese zero COVID. Shanghai, it's not working. I'm not sure it's working in Beijing. Hong Kong I look at because at least I believe the data coming out of there. I'm not sure I believe the other data. And Taiwan was a good example of doing it as well, and they're more realistic. So I think China's going to have a problem because I think this is impossible to stop. They still haven't vaccinated enough of their population, particularly the elderly, and I hope they're pulling out all stops to do that and doing it silently behind the scenes because it's a problem if they're not. How does it spread? Well, basically you can spread it by breathing it in. You can touch something and touch your nose. And we do sewage testing because it's in faeces, but it doesn't seem to spread much by faeces and water, thank goodness. It probably doesn't spread a lot by touching, and, you know, so quite rightly, I think hand hygiene is really important. We all should do it very frequently, but in the realistic real world, most of it is you're breathing in. Now, this is where it's controversial again. I'm at the moment a pariah, I think, on Twitter because I think most of the spread is through larger particles called droplets rather than aerosols. Now, why is that important? I think all the data suggests it's close proximity and time. If it's aerosols, as I've said before at meetings that David's organised, we're all screwed. Because the theory of aerosols is that they can go 10, 20, 30 metres. Somebody comes into this room, it stays in the air for hours. You know, how could you have public transport? How could you have anything you could do? Well, you know, there's no way of stopping it. And one of the big evidence, I think, for not being a lot as aerosols is New South Wales in their quarantine hotels had close to 700 or 800 infected people in apartments that were run by the Prince Alfred Hospital Group. And I went there as part of the Commonwealth Review. They wore eye protection, they wore surgical masks. Not one staff member got infected. Now, if aerosols were a big deal, they should have had lots of infections because, you know, their eyes were, from sideways, and the surgical mask is not working as well as N95. So it's not that aerosols don't happen. Yes, they do, but I still think that it's less than what is being made out at the moment. And, you know, this is just a figurative. If somebody coughs, you'll get particles of various sizes. And some will be small particles called aerosols. But that's not where the majority of the virus is. And the reality is that's not how much of the spread occurs. Even in aeroplanes, it's mainly people who are around the person who's infected. Again, reasonably close proximity. I think the problem with the droplet theory is it can go 3 or 4 metres if the wind's behind you or there's a breeze behind you. But in all the quarantine hotels, as far as I can remember, only one person in South Australia ever got infected who was supposedly wearing eye protection in the form of a face shield and a surgical mask. So again, yes, you know, nothing's absolute, but if you do the right things, you run a really low risk of doing it, of getting it. Eye protection I've mentioned. You know, your eyes are very important. In the original, some of the Wuhan outbreaks, people who wore glasses had a 7-fold lower risk than people who didn't wear glasses. Now, people who are richer can afford glasses, so there's a thing. But in a study in England where they looked for that, they found a 15% reduction in your risk if you wore glasses and not if you wore contact lenses. So your eyes, I think, are important, and that's as much a protection as you get from a mask, I might say. So I think the eyes are really neglected, and I think and I think at an individual level it works. But when you look at all these mask mandates, you're hard pressed to show, at least now, that they're working. You know, if you look at an epidemic curve of one place in the US and the counties near it, they look the same. You know, go up and down. So I think masks are worth wearing for an individual if you're at risk, but I think fining people because they don't wear it, I'm not sure you can really convincingly show that improves public health. Ventilation, I think, is important. I've just recently had a paper published that I did with somebody in England that shows, it's not new, it's been known for 100 years, we keep on forgetting it. Outside air has factors in it that kill viruses and bacteria. The germ warfare people knew that. And so that's why ventilation is important, is, you know, our new buildings where we have, you know, preserve energy and they are an increased risk. The old-fashioned ones where you could open windows, have ventilation, that actually is protective. And why being outside is 20 times less of a risk to you than being inside. You know, have your barbecue outside. Testing PCR in rats, again, that was a political thing. Rats were never very good relative to PCR when you want zero COVID or really low levels. They miss 20% of the cases or 50%. Now, in fact, perversely, they're better because they are a better indicator of infectivity than a PCR test that can stay positive for a month or two. So what tests you use depend on what you're trying to do. And I think now rat tests are a good idea, but I did not think it when everybody was making a noise about them about a year ago. And so in summary, where is Australia? I think we're pretty good. I think we're going to end up much better than most of the rest of the world. But I'll wait a year before I get too dogmatic about that. Winter is here. I think we're going to have more cases because viruses just spread more readily in winter. But equally, I'm a bit surprised we've had so many cases over the last 6 months. So perversely, we may have less cases this winter than I was expecting because so many people have been infected in the last 6 months in Australia. High vaccination rates are important, and it's particularly important for anybody over the age of 50 to get at least a 3rd shot. And I think if you're 70 or 80, a 4th shot. How much value from that 4th shot, we don't know, but you know, I would err on the safe of overdoing it if I'm a 70 or 80-year-old. Ongoing restrictions, well, I think it is worthwhile having some restrictions about crowded indoor venues, but how you do that in a practical way, I'll leave that to others. I think Europe and North America, they're not as good as we've been, and they will end up worse than us. And we've got a big advantage of better outside weather, if nothing else. But low and middle income, that's where there's a real problem. They still have had poor vaccination. They don't have access to the same drugs we've got because they're expensive. So there's a real problem, and this really is a global problem. What happens in Brazil or Southeast Asia affects us because that's, you know, Delta probably came from, or probably from India, but, you know, strains will develop. So we need to get the world vaccinated, at least to stop them dying, and doing what we can to, you know, decrease spread without being over the top, but also stop people from dying, I think is the main thing globally. So at that stage, I'll finish.